So, on behalf of Merck India, I am Juhi Gupta from the Oncology Marketing team, and it's my pleasure to welcome you to this special Lung Cancer Awareness Month edition of MedChat, which is focused on optimizing outcomes in METex14 skipping NSCLC. So, we have an exciting agenda ahead with us today. And in the next 1.5 hours, we plan to cover various topics right from NGS testing to precision practices to real world insights, and also finally a panel discussion as well. And it's an honor today to have with us an esteemed panel of experts, and also a special thanks to our international speaker, Professor Dr. Martin Dietrich, who has joined in quite early from the US, and he's here to share his deep expertise in precision oncology. So, with that, now I would formally begin the session, and I'm delighted to introduce our chairperson for the evening, Dr. Advani, sir. He truly needs no introduction. He's one of India's most respected and pioneering cancer specialists with over 4 decades of experience in medical oncology. He contributes to bone marrow transplantation, immunotherapy, targeted therapy, and precision oncology, and have set benchmarks globally as well. He has represented India in leading forums like ASCO and ESMO, and his work has earned him prestigious honors, including the Padma Shri and the Padma Bhushan. With that, I would now like to invite Dr. Advani, sir, to set the context and kick off this insightful session. Sir, over to you.
Yeah, good evening, colleagues. First of all, I would like to express my thanks to the organizers who have given us this opportunity to discuss a little bit rare subject. And I must admit that information, up to date information, will certainly help all of us to really pay little more attention to this area. As everybody knows, that today the lung cancer needs the genetic analysis to find out really the mutation. And then, based on the mutation, directed therapy is the choice. So, this is what we call it targeted therapy. And common mutations which we see, EGFR, ROS, ALK, they have got a standard good treatment and it works very well. Rare mutations are, of course, we all of us see a lot of rare mutation. One of them is the METex14 skipping alteration in the gene in non-small cell lung cancer. And today we have the experts, not only from India, but also abroad, where we will be really discussing about the role of diagnostics in identifying the alteration. And also we'll see that how we can explore the therapeutic direction for the METex14 skipping. And this will be done by sharing of the experience and also trying to understand the strategies for managing the adverse effect due to some of these TKI. So I think with this little introduction, I would now like to really move forward and request the next Dr. Bahal,
Thank
Dr.
you.
Charu Bahal, to really give us an information about the NGS testing in the lung cancer in India. I must tell you that now no lung cancer is treated without NGS. That has become the true guideline all over India. Even in the small villages, people know that for lung cancer, NGS has to be done. And to some extent, I must say that it has become within the reach, which means it has become really cheaper and cheaper. So I think your information will give us a very good idea about how you are able to do all these things effectively. Thank you very
Definitely.
much, Dr. Charu.
Thank you. Thank you so much, Dr. Advani. It's a Really a pleasure to be here sharing the platform
Hopefully.
with all the esteemed faculties. So, if I can have my slides.
Pull up.
So yeah, so as Dr. Advani rightly set the context for me, so I am going to just talk about the evolution of NGS testing in lung for lung cancer in India. So probably, as the background, we can see lung cancer is leading cause of death globally, but for India, the survival rate is approximately 5 year survival rate is approximately 10%, reflecting late diagnosis and aggressive disease biology. And if we look at Asia overall, there are a lot of patients which are never smokers and are developing lung cancer very swiftly. The integration of NGS based driver mutation profiling had clearly changed the scenario, and it's like a it has become like a poster child for targeted therapies, probably for lung cancer. We have various guidelines which tell us to pursue these testing, and it is kind of, as Dr. Advani mentioned, it is kind of a routine practice now to have at least a minimum of 12 to 10 to 12 genes to be tested, which includes EGFR, KRAS, BRAF, HER2, METex14 skipping mutation, and various fusions like ALK, ROS, RET, and NTRK. So, next slide. So if we see the progression of the testing, it starts from early 2000s, wherein we were only testing single genes, which included EGFR and ALK, and probably with the passing of the time, the technologies which were used were PCR and FISH based. Probably for ALK, EGFR, and ROS. So we were just having therapies for these three particular targets, and that's how the genetic testing platform and the journey for lung cancer started. And as soon as the technology advanced and the number of targeted therapies increased, it moved to NGS and complete genomic profiling, where we are now doing mostly multi-gene NGS and broader panels, which includes SNVs, indels, which are point mutations, small insertion deletions, copy number variations, and translocations. And newer targets are coming up, which are needed to be tested, because the population having lung cancer is probably increasing, and that's why the prevalence of rarest mutations is also very high if we look in Indian context. Now, from NGS, now the new era is coming for liquid biopsy, which started from around 2015 onwards. And ctDNA and minimally invasive CF cell-free DNA testing became like a very important approach for lung cancer patients, wherein tissue availability and getting the biopsy was an issue. So definitely a plasma first approach was kind of put forward in the 2020 onwards time. And as more and more new therapies came up, the era of resistance and clonal evolution came up, and that's how rebiopsy and doing liquid biopsy based monitoring, longitudinal monitoring, became more and more important. And that's what we are here today. In the present, we are doing multiple testings at multiple time points for a single patient using different samples, be it biopsy sample, be it liquid biopsy, to interpret and to understand the tumor biology and to understand various metastatic sites in one go. That's how it has evolved over the years. So next slide. So if you look at the workflow now, it basically, we have two options. One is to go for NGS right away along with PDL1, which includes around 12 to 18 genes, which initially, as per availability of the platform, has to be done. Even NCCN guidelines and all other ESMO guidelines, they probably ask us to do a broader gene panel, which basically covers complete gene and not only hotspots. So definitely, because more and more uncommon mutations and rare mutations are being reported. So that's how I think option A is what we are going for these days, and probably that is what is the need of the hour. Next slide. So if we look at the technologies which were being used earlier and now, obviously FISH and IHC have not completely lost their relevance because they do pitch in at different time points. But the leading thing which really helps is RNA and DNA based sequencing, because if we look at the translocation detection or complex genes such as MET exon 14 skipping mutation, RNA sequencing has really led the way, because it can look into intronic region mutations as well, and it can look into intronic region splice sites. If we look at the translocations, fish can give you the particularly give you the might not be able to give you the partner, which partner is basically translocated with a gene like ALK or a gene like ROS. If we are using a specific probe, only in that case it might give you. IHC definitely gives you an overexpression and underexpression, and it is a tool where you can where it can give you an idea if there is a cryptic translocation. So if we move to RNA sequencing, you get a comprehensive view whether which partner is there, what is the breakpoint, and what is the whether that protein is actually being translated or not. So these three things we get ideally in RNA sequencing. Next slide. So if we look at MET gene alterations, we all know there are several types of alterations which are reported, which include MET overexpression, MET gene amplification, MET mutations, including MET exon 14 skipping mutations. And if we look at the frequency, definitely MET exon 14 skipping mutations are found in 3 to 4% patients. Next slide. So, how relevance of RNA sequencing is there in detecting MET exon 14 skipping mutations? Because if we look at the procedure or the the process by which this mutation occurs, it is by looking at the exon 14 splice site, which is there between exon 13 and 15. So, if MET exon 14 skip is being skipped, it could be because of the intronic region splice site, and that we can only visualize using RNA sequencing. If we are not doing RNA sequencing and the splice site is deep in the intron, we might miss that particular variant, and it has happened a lot of times, which we see. So definitely RNA sequencing allows the direct visualization of the exon 13 and 15 junction. It provides you confirmation that exon 14 is skipped. So here you can see, basically this is the sample of interest, this is the control sample, and here you can see the expression of RNA in the exon 14 is very, very less. So that's how we are able to eliminate the ambiguity which we see only with the DNA only predictions of the splice events. That's how you should be very, very clear about the fact that if you are looking for MET exon skipping mutation, RNA sequencing is what is the need and what will give you the exact clarity. Next slide. Can I have the next slide? Hello. Can I have the next slide?
Dr. Khushi?
Can I share my screen?
Sure, ma'am. Otherwise, I can also share.
Is it visible?
Yes. Can you
Okay.
go to the full screen mode?
Yeah, I'm in the full screen mode now. Okay. So the
Uh,
last slide which I want to basically highlight is our own internal data at MedGenome. This is the data of 2,616 samples of lung cancer which we have performed on tumor tissue. You can look at the positivity rate, around 60.67%
Ma'am,
patients.
we are not on that slide actually. What we can see is still the comparison. Yeah, yeah.
Yes.
Okay.
Now it's visible.
Yeah. Okay, so probably the next slide which I want to highlight is the internal data on the 2,616 samples which we have performed on tumor tissue at MedGenome. If you look at the positivity rate, it is around 60.67% patients were found to have oncogenic mutations, which included both Tier 1 and Tier 2. Tier 1 mutations were found in 26.2% patients, and if we look at the major mutations, obviously EGFR has around 57.9, that is around 56% positivity rate. and if we look at MET, it is about 2.52%. So which matches, around the international standards as well, which rounds to around 3%. So, and we have reported around fusions in around 401 patients. Maximum number of fusions reported include EML4 ALK fusions, and then some rare fusions of ROS, and different partners of ALK have also been reported, along with 9% RET fusions. If we look at the internal data which we have at MedGenome, there is a rapid increase in the uptake of NGS for lung cancer. As per our internal statistics, we have seen an increase of almost 40% in the sample numbers from 2022 to 2025. So this is how increasingly, uptake of NGS is increasing in India. But we have to be very, very sure. The key takeaway is that for MET exon 14 skipping mutation, RNA sequencing is what we need in order to completely understand and be sure that the exon 14 is being skipped from the junction, because the splice site is deep in the intronic region. So that is what I will end my talk on. And thank you so much for the opportunity. And I look forward to the coming session. Thank you so much.
Thank you so much, Dr. Charu, for those insights. And we'll move to the next part of the agenda. And for that, I'll just share my screen.
Before that, is anybody from the mice team available and can share their screen, or shall we do it from our end? Go ahead, Joey. I got no response. Please go on.
Sure. I hope my screen is visible.
Yes, Joey.
Great. So, thank you, Dr. Charu. With that, we'll move to the next part of the agenda, which is epidemiology of rare NSCLC mutations in India. And for that, I would like to invite Dr. Vaishnavi Joshi. Ma'am is a medical oncologist at Aster Hospital in Bangalore. Ma'am, over to you.
Thank you so much. Hope I'm audible.
Yes, ma'am.
Yeah. So should I share my screen or you will do it? Okay.
I can do it if you are comfortable with that.
Yeah,
Or,
sure.
yeah,
Okay. So thank you so much for this opportunity. I'll be talking about a brief overview on the epidemiology and epidemiology of lung cancer and the rare mutations landscape in India. So to start with, as we all know, the disease burden of lung cancer is increasing. We have staggering numbers, both globally as well as in the Indian scenario. So globally, around 2 million cases, new cases being detected, and in India, about more than 80,000 cases, new cases, and adding up to the mortality or the deaths up to 8.2%, it contributes, lung cancer itself contributes to the cancer deaths in India. NSCLC, the non-small cell lung cancer, accounts for about 80 to 85% of lung cancer cases, with adenocarcinoma being the most common histology. Overall, India is the fourth highest contributor to lung cancer incidence, and lung cancer accounts for about 8.5% of all cancer cases in males, and 3% in females. As we know, in males, it is the second most common cancer. In females, as we see in our practice, the lung cancer incidence is also increasing in females. It's still the seventh most common cancer in females. Next slide. So with these staggering numbers, also the disability as adjusted life years, if you compare from the ICMR study in 2004 to 2021, the DALIs, or the disability adjusted life years, has significantly increased. Now lung cancer contributing to around 116 DALIs per 1 lakh. So it has become the top one cancer, that is number one cancer with highest number of DALIs per 1 lakh. So this shows the increasing incidence of lung cancer and its burden on the society. Next slide. So coming to targeting oncogenic drivers, tissue biopsy and liquid biopsy in clinical practice, with a special mention to Indian scenario. So as we know, we have reached, in the last decade has been the era of precision oncology, and lung cancer has been the blue-eyed boy, or you can see the star of precision oncology. We have.
నువ్వు కిందది పెట్టి చేయి అన్నావు
Sorry.
రెండు పెట్టు
So
కిందనే పెట్టి చెయ్యు
can
అన్న
I continue?
Yes, yes, there is
Yes,
some.
In
ma'am.
We will
Yeah.
just ask. Can I? There is somebody who has joined with the name of iPhone. Can you just go on mute? Or the backend team, can you just take care of it? Sorry, Dr. Vaishnavi, please
No
go on.
problem. No problem. So this has been an era of precision oncology, and more so, the prototype cancer has been non-small cell lung cancer. If you take up adenocarcinoma, about 60% of patients have oncogenic driver mutations. If you can see the left chart, if you see there are number of mutations, mostly EGFR, which has transformed the way we treat lung cancer, and has been gratifying in the last few years to treat some of these lung cancer patients. And 50 to 80% of squamous cell carcinomas also have oncogenic driver mutations. So oncogenic driver mutation identifications has definitely increased, or it has improved treatment outcomes. Next slide. So, as far as the molecular testing and the molecular evolution as far as the lung cancer diagnosis and classification is concerned, it has evolved over the years, starting with histological breakdown from squamous cell to adenocarcinoma, large cell, to now we have come to molecular classification with molecular markers EGFR, ALK, MET, ROS1 being utilized for diagnosis and treatment of lung cancers, with the PDL1 expression less than 1%, 1 to 49%, and more than 50%. So this is what has happened in the last few years. And one of the common mutations which we are common targets which we are testing is around 7 or 8, which includes EGFR, ALK rearrangements, ROS1, BRAF, RET, NTRK, and METexon, and most of this having targeted therapies respectively. Next slide. You can go back to the slide. Yeah, previous slide. Yeah. So from all the guidelines now, we know that patients should be assessed for actionable biomarkers before starting first-line treatment and throughout their treatment course. And the testing predictive biomarkers in SCLC is the key to guiding targeted therapies and also to improve patient outcomes. And clinical guidelines also recommend rebiopsy and biomarker testing after progression on first-line EGFR inhibitors to detect emerging targetable alterations. Next slide, please. So coming to biopsy methods for detecting this specific MET exon 14 skipping mutation, which we are all talking about today, expert guidelines for treating patients with NSCLC recommend biomarker testing, which includes MET exon skipping mutation, which can be identified by tissue or liquid biopsy. So all the guidelines, including NCCN, ICLC, ESMO, recommend broad molecular profiling for oncogenic driver, including MET exon skipping mutations. So tissue biopsy is the gold standard for targeted therapy with this MET exon skipping mutation, with our DNA and RNA isolation and purification. But liquid biopsy can also be used, and these two can be used complementary, and which can provide increased flexibility in biomarker testing for patients with non-small cell lung cancer. As far as tissue biopsy is concerned, I think the previous speaker has spoken about the various methods which we use, but most commonly used even in India is the next generation sequencing to detect all these markers to guide treatment. Next slide. So are we flexible in biopsy options? While tissue biopsy is the gold standard for testing MET exon skipping 14 mutations, but liquid biopsy can provide additional value and flexibility for patients who are not suitable for tissue biopsy. So if you compare tissue biopsy and liquid biopsy, as we all know, tissue is invasive, risk of complications are high and not suitable for for all patients, but sensitivity and targeted collection wise, this is definitely superior to liquid biopsy. It's not about a debate of which is superior, but both should be used complementary to each other. However, for first choice of the gold standard biopsy option for identifying patients who are eligible for TEPMETCO is tissue biopsy, and liquid biopsy can be used if tissue biopsy is not possible due to factors like comorbidities or frailty of the patient, or if so liquid biopsy can be a viable alternative. So is it superior to tissue biopsy? In certain ways, it can show, it can be better representative of view of genetic variations, tumor heterogeneity, and also liquid biopsy provides a real-time assessment of tumor burden, disease progression, and also early detection. Next slide. So what about, should we test all the mutations, all the alterations sequentially, or do an upfront NGS? If you ask me, I think most of us are doing upfront NGS in our practice. So compared to sequential testing of EGFR, AL, cross negative patients, upfront NGS testing, it's actually studies shown that it resulted in about 1% of patients with additional 1.2% of patients with actionable alterations for targeted therapy being identified. And so detection of complex EGFR alterations, variant ALK fusions, ROS1 fusions also improved by using the upfront NGS, that is the upfront sequencing. And also in squamous histology also depicted about MET exon skipping mutations in about 2% and KRAS G12C alterations about 4.7%. So I think we've all shifted our practice to upfront NGS compared to few years ago. Next slide. So coming to the Indian perspective, do we have the real world data on these driver mutations? So this is a paper from Agarwal et al. Pathology Research Practice. So about 500 patients, about 60%, about 320 patients had minimum of one genetic alteration involving EGFR, ROS, BRAF, MET, and others. One interesting fact which came out in this was MET and BRAF was more common in elderly population. EGFR, AL cross rearrangements were more prevalent in the younger population. So this is one of the Indian study which showed driver mutations in NSCLC. Next slide. And this is another paper with ctDNA or liquid testing. Plasma samples were checked with our own sir, Dr. Amit Ratan sir's paper. So genomic landscape of NSCLC in India using circulating tumor DNA. So clinically relevant biomarkers were detected in more than half of these samples in Indian patients. EGFR accounted for about 28.6%. Interestingly, MET was also found in 5% of these patients. Next slide. So to summarize, India is the fourth highest contributor to lung cancer incidence globally after China, US, and Japan. I think we cannot overemphasize the importance of molecular testing for assisting selection of targeted therapies in NSCLC. And NSCLC biomarkers can be tested via tissue or liquid biopsy. And some of the recent Indian studies have documented the prevalence of driver mutation in line with our the Western data in Indian NSCLC patients, and we need more larger patient numbers to do these studies. Thank you so much.
Thank you so much, ma'am, for that insightful presentation on epidemiology of NSCLC. With that, now we'll move to the second part of the agenda, which is precision in practice, enhancing outcomes in METexon 14 skipping NSCLC. And for that, I would like to invite our international faculty, Professor Dr. Martin Dietrich. Sir holds a dual. I'm sorry, I think you guys are sharing it. Okay, thank you.
Sir has shared from his end.
Okay, okay, sir, no problem. So, as I was introducing Sir, Sir holds a dual doctorate in cancer biology and also molecular genetics. He's completed his residency and fellowship in internal medicine and hematology oncology. He is currently associated and practices with Florida Cancer Specialist and Research Institute and holds an academic appointment as professor of internal medicine at the University of Central Florida. He focuses an interest area is thoracic malignancies and breast cancer, with a strong emphasis on integrating molecular and genomic diagnostic. He also has authored over 38 key publications and has significantly contributed to the advancement of targeted therapies and biomarker driven therapies. So, sir, we are delighted to have you with us today. Thank you so much, and over to you.
Thank you so much. It's a pleasure to be with you here today, and I'm looking forward to sharing the next 25 minutes with you. I'm a geneticist by training, so for me, making lung cancer a genetically defined disease has been a career-long passion, and MET is a very interesting, a very versatile biomarker, so I think it deserves a good focus, and I'll try to be as practical as possible here. Obviously, when we look at MET, there are different alterations that we're looking at, and we already heard from Division and others that MET obviously doesn't come in one flavor. We see in lung cancer two types: the MET exon gene amplifications and the MET exon 14 skipping mutations. And the MET exon 14 skipping mutations are unique in the way that they're activated through not an increase in production, but a lack of turnover. So we're looking at the biology for MET exon 14 from a different way, but clearly an actionable oncogenic driver here that has very good therapeutic opportunity for patients. When we look into the subset, we mentioned the mutational presence not in the exon regions of this tumor, but actually in the intron region, triggering a splicing event that removes exon 14. So we're basically seeing a truncated molecule that goes from exon 13 to exon 15 and DNA transcription, and allows for a truncated protein. Now, why is exon 14 important? Exon 14 binds the C-Sybil ubiquitination protein, and is essentially the main source of protein removal from the membrane level. So by having an absent C-Sybil binding domain site, we're really dependent on a proteolytic turnover that is non-specific and is certainly much smaller. And instead of having overexpression like we see with an amplification, we have here a decreased turnover. And it's very important to understand that when both receptors have different mechanisms of activation, their impact is very similar. So we see MET overexpression as a bona fide oncogenic driver. Obviously here the level of amplification is important. And obviously we see also MET exon 14 skipping mutation here as a unique biological entity, and we should be very careful not to mix them. So this is how this looks when we essentially have a truncated receptor. Exon 14 gets cleaved out, and exon 13 and exon 15 fuse on the protein level. We mentioned DNA and RNA-based testing. I think this should be standard of care. They complement each other. They have individual strengths. mRNA is not better than DNA, but it's different for amplifications. It's very nice to have the data on a DNA level. We can very nicely quantify amplification events. We can look at higher genomic alterations, but for fusions and for translocation events, as well as post-transcriptional events like we see here in the splicing of exon 14, mRNA is clearly superior. When we look at the mutational landscape, we see a distribution here, and KRAS and EGFR obviously dominating the different subsets. And then we have this large array of lesser oncogenes, lesser frequency oncogenes, and that are still representing thousands of patients. So they're not insignificant, and they're certainly worthwhile detecting for each individual patients because it's their main driver, their main biological hallmark, but also their main therapeutic opportunity. And you can see here RET, ROS1, NTRK. We see the NRG1 fusions for which we have sacituzumab, MET exon 14, BRAF. We're still working on targeting NF1. We simplified KRAS and EGFR here. Obviously, those are very complex families of markers that have different treatment approaches and different opportunities for KRAS and EGFR respectively. So a very quick development that went from basically carbotaxol into the broad and complex landscape that lung cancer presents today. So when we think about what the standard of care is, and I think that's a really good idea to look at where we're at in terms of data. You can see here essentially a comparison between patients that have been treated with a chemotherapy plus or minus immunotherapy approach. And you can see here a median overall survival of 8.1 months with the MET inhibitor added on. 24.6 months, so more than threefold the length of overall survival. And I think this really highlights that we don't have any good options that are particularly responsive, lung cancer, or particularly chemotherapy resistant disease. And we've seen in this and other studies that immunotherapy is not a very receptive biomarker, even though we see these falsely elevated PD-L1 levels that are going along with the MET pathway activation. And we really need to unlock the core of the biology here to improve outcomes for patients. And 8.1 months is really in line with what standard chemotherapy would provide 25 years ago. Here you can see the correlation between METex14 and tumor mutational burden. Is always a question. How do these cancers originate? And I think there's a fair statement to be made that patients that have less mutations are less visible on the immune radar and therefore predictably less favorably responding to immunotherapy. You can see the ones that have the most mutations are patients that are having KRAS or alternative BRAF mutations, and oftentimes they come with elevated PD-L1 levels. So the combination of elevated PD-L1 and tumor mutational burden synergizes to be prognostic in the response to immunotherapy. As you know, for KRAS, we're currently prioritizing immunotherapy, but it's really the only marker that breaks from the paradigm that when we have an oncogene present, that we should be not using the targeted therapy first. The NCCN guidelines have updated accordingly. So it used to be that when you had not EGFR and ALK, but one of the other mutations, that it was basically dealer's choice. Whoever wanted to go first, immunotherapy, chemo, or targeted therapy. This has changed to the point that not treatment till progression has been recommended, but treatment until the detection, and then a delegated switch for treatment. Here you can see the performance of treatment here on the right side. You can see the differences between standard therapy and patients that are receiving MET inhibitors here, clearly benefiting significantly. When you look at the real-world analysis of patients here with first-line targeted therapy as compared to a non-specific IO monotherapy or IO chemotherapy combination, it comes as no surprise. I do want to point out, if you look at the turquoise and blue curves here, they are virtually overlapping. They are not changed. So the impact of immunotherapy here is really not evident. And we have about a five-fold increase in progression-free survival in comparison against IO monotherapy, at least a doubling compared to targeted therapy. And obviously, chemotherapy remains an option in these patients for patients that are progressing on Tepmetko. So it's clearly a superior therapy. We have gotten a final approval by the FDA for tepotinib or Tepmetko, so there won't be any head-to-head study. And if I look at this data and look at the patient experience, it's certainly also not desirable. We always like to have phase 3 data until we actually have to have a patient that has to go on the chemotherapy comparator arm. Nobody would want that for themselves or their families. Here you can see ESMO and NCCN guidelines are closely aligned here. METex14 skipping recognized as an individual entity. Tepotinib here recommended as a preferred first-line therapy, but also for subsequent therapy. I do have to say, if I compare the data, and so it's not statistically randomized, but if I compare the data between first and later line, the first line, the responses and duration of responses, certainly better. And in my opinion, crizotinib, because of the lack of brain coverage and the lesser durability and off-target effects, really doesn't carry a big role in this anymore. So when we look at the VISION study as the registrational study here, enrolled over 300 patients, a very large clinical trial, the first one to have both liquid and tissue biopsy validation. We see liquid biopsy here is a very valuable tool, especially in patients. And I think this was a little bit of a skewing in the data, that the patients that had been offered liquid biopsy here were not mandated to receive it, but they were done by clinicians' discretion. So many of these patients had larger tumor volumes, so this cohort did tendentially a little bit worse. But I think those were just more acute patients for which the inclusion of liquid biopsy was meant to accelerate treatment enrollment. We have a typical patient population, and very different, distinctly different from EGFR and ALK, where we have younger women. Here this is older males, and typically patients that have had a significant smoking exposure. You can see it in never smokers as well. So as we always, that's why we do NGS. We test everyone for everything and see what the biology reveals. And then obviously it was tested line agnostic, both treatment naive and previously treated, with a substantial portion of brain metastatic patients were included here. You can see the different cohorts. Cohort A and cohort C were included here in treatment. The single arm nature here was recognized. And then these two cohorts were joined for patients with METex 14 skipping mutations that had either treatment naive or previously treated exposure. And you can see primary endpoint here: overall response rate, duration of response, progression-free survival, overall survival, and safety as secondary endpoints. Older patient population, median age here 74. Here a good enrollment in Asia, about 30%. Smoking history in the predominance of patients here. Adenocarcinoma is the predominant histology, but when you think about testing, it's always important to recognize that mutations like KRAS, BRAF, and MET can cross histologies into the squamous line. We learn a lot about squamous biology. Here you can see squamous and also the sarcomatoid subgroups, very enriched for MET. About 30% of patients with sarcomatoid lung cancer here with the c-MET alteration. Here you can see the data with regards to efficacy. There's an intrinsic consistency between many of these data subsets. The cohort A and C had a response rate of almost 60%, a median duration of response of over 30 months, 31.7 months, a median PFS of 12.6, and a median overall survival of 21.1 months. So there is a big discrepancy between the responders and the non-responders. So the first scan here has a high level of prognostication for the patient, and there was clearly activity in first and later line settings. There were no safety signals that were divergent, and you can see first line clearly doing better. So the introduction of resistance mutations and other factors of drug resistance that chemotherapy can bring, certainly challenging lower response rates, lower PFS, and also lower median overall survival for patients that have not responded here. So the ideal patient is done first, which is why NGS upfront, mentioned many times today, should be the standard of care. You can see the median duration of response first and later line. I think these data sets side-by-side comparisons are difficult. I think one of the most compelling arguments, clearly better for first line, but one of the most compelling arguments is that we lose about 25, it's a pretty consistent number, percent of patients between first and later line. And obviously, if we don't give it in second or line and third line, even further. So the best therapies first and getting a patient a targeted therapy as early as possible, really critical. You can see here again the markers side by side here by biopsy method, tissue and liquid biopsy. You can see that the liquid biopsy tendentially looks worse. There was some retrospective analysis done that looked at tumor volume and tumor burden, and liquid biopsy, those were just patients with higher tumor burden. They would expectedly do worse. So somewhat the numbers skewing down. We're seeing here the response rates in the brain. I think that's very reassuring. We always look for patients that are doing well, and you can see here when you compare present and absent brain metastases, the response rates are very much similar. The duration of response somewhat short. I think this goes along with the higher duration of response, but this is clearly a brain active agent that we can utilize. I think this is not an unknown phenomenon. We've seen this with EGFR and other oncogenes, that their presence in brain metastases really confers a negative prognostic impact. Now, when we think about the quality of life in patients with METex 14 skipping, we have to contextualize this metastatic cancer patient on chemotherapy that we're looking at here as a benchmark comparison. The quality of life here actually is preserved, and the time to preservation is just about the same as the time to tumor control. So this is really a correlation between what we're seeing here, between how long can tepotinib control cancer and how long does it take for a patient's quality of life to improve. And yet you can see, if anything, that the patients have ongoing improvement in their treatment and symptoms that are quite important for our lung cancer patients, of cough, dyspnea, and chest pain. So this is a very important recognition. We do not only improve the quantitative markers, but also the qualitative marker for our patients. The same is true here for the distribution by metastatic site. Everybody here maintains quality of life for the different markers of chest symptomatology, independent of this distribution of disease in the adrenal glands, bone, liver, and brain. So the quality of life, I think this is a very fair statement to say. We've seen substantial relief from some of the core symptoms afflicting our patients, the METex14 patients here responding independent of disease distribution. We see an improvement in these symptoms. And again, if we have had a correlation to make, it would be best therapies first. The time when patients deteriorate here and their quality of life is when their tumor progresses. Now, a competitive analysis here between tepotinib or tepmetko and capmatinib. Pragmatically, in the US, we prefer tepotinib because we use it once daily. This was always making it easier for patients, improves compliance. Here, a matching adjusted indirect comparison for treatment. This was published, and we looked at different markers here between the vision study and geometry mono 1, and that has had similar patient populations enrolled in treatment. Tepotinib here, somewhat longer, larger follow-up patients in treatment. You can see that treatment regimen here a little bit different, 450 milligrams daily, capmatinib 400 milligrams twice daily. And when you compare tepmetko in both weighted and unweighted comparisons, the data here does look favorable compared to capmatinib in the geometry study here for treatment. PFS on the left, overall survival on the right. And again, when we look at both matched and unmatched comparisons, they do look actually quite overlapping in the way they are presenting. So I think that's an important feature here. In the second line setting, we see a very similar picture, an early and a continued separation of the curves favoring tepmetko in the vision trial, both in a weighted and in an unweighted setting. Capmatinib here not looking quite as well. You can see the overall response rates also lower, 49% for tepotinib, 40% for capmatinib, and longer duration of response for a larger population here between those two studies. The last chapter here that I want to touch on is the A management of TKIs. And if I look at the side effects, I think it's very important to understand what MET does in the body. We have a control of vascular integrity that is regulated by the activity of MET. So when we inhibit MET, the peripheral integrity, especially in the capillary bed, will decrease. What are the side effects? Obviously, when a vascular bed is becoming fenestrated, we can see edema on the outside, but we can also see pleural effusions on the inside. We can see ascites, we can see scrotal edema. Those are important features to recognize. We can see consequently a leakage of albumin, so hyperalbuminemia is a very common concern. And if it's significant, we can see downstream effects of intravascular depletion with an increase in creatinine and electrolyte shifts. A drug unrelated, which we see with all target inhibitors, ILD pneumonitis. This is an inflammatory allergic type reaction that is not quite as common. About 3% of patients afflicted here. But the edema dominates all of the patient experience and all of the side effects that we need to manage. And this is an on-target effect. This is not a side effect of the drug. MET inhibition is what the drug is supposed to do. The target structure is the same. We see a non-differentiable receptor presentation. So we have an absence of a target structure, not an addition or mutation of a target structure. So very important to understand that the only way of manage this in more significant cases is through dose adjustment. Here's the suggestion. These treatment-related adverse events are common. The class effect of CMET, capillary permeability goes up, the plasma oncologic pressure drops, and we can see this in many ways for treatment here. And it typically starts early on, so we see this within the first few weeks. So if a patient experiences edema, we need to learn about this and tell the patient to intervene here. What do we do? Obviously, for milder cases, we can do supportive measures, elevation of the limb, compression stockings, sometimes a lymphedema-like massage, a drop in salt intake. I think the most important one here is still the consideration for dose adjustment. We have very nice data, actually, that the dose adjustments here do not jeopardize outcomes for patients. You can see here when you look at the side effect profile, again, the edema here towering over all of it. And again, this is a predictable on-target effect. You cannot target MET without inducing edema. We see, I mentioned this earlier, the convenience of the once daily dosing. You can take it with or without food. You can dissolve it so that patients that have difficulty swallowing can take it. We can give it through NG or PEG tubes if necessary. So a very nice way of giving this. And it's dispensed in 225 milligram tablets in the US. And so those adjustments are really require only the reduction from 2 to 1 pills, which both saves money and time and effort when it comes to those adjustments. And then some patients really do need them if the edema is significant. So I think in summary, I think tebatinib I really addressed a great deal of unmet need for METex14 skipping mutation. The data here very strong in the brain and the body with long follow-up. Many patients, over 300 for a relatively rare oncogenic driver. We see very favorable presentation, both in factors of convenience that the patients experience, but also in their efficacy markers when we compare the two registrational studies of geometry and vision. The tebatinib here clearly an edge for efficacy and as a take-home message for the side effects, edema. We see this with the MET antibodies. We see it with the MET TKIs. Early intervention and proactive management with supportive care and potential dose adjustment, really here a winning concept. This typically happens in the first couple of weeks to 2 to 3 months, not longer. And we know very early on who the patient's going to be that's going to develop significant edema. The patients will be able to tell you. I call them. They don't really necessarily have to come in. They'll tell me my shoes don't fit as nicely anymore. And then we can intervene. We say, stop the drug. And then we go down on the dose if it is significant. With that, I do want to thank you, Julie, for the invitation and for being with you today. And I'm very much looking forward to our panel.
Thank you so much, Professor, for that insightful talk and really nice to hear your perspective on this topic as well. So now, with that, we will move on to the next part of our agenda. And is anyone present from the mice team?
Uh, yes.
Yeah,
I'm
can you please share the screen?
full screen. Can you please do the full screen? Yes.
Okay, thank you so much. So the next part of the agenda will talk about the real world insights, Indian experience with TETMEDCO. And for that, I would like to invite Dr. Ankur Vashne.
Hi, good evening. And you need to share my slides. I'm still not used.
Sure, sir, we'll do that.
Okay,
Can we
thank you.
move on with the
Yeah.
slides?
Hmm. So, hi, good evening. And after a wonderful discussion, now we are going to have some real world insights with Indian experience with the portal. Next slide. So, this is a case study, a real life case scenario, which I am treating. Next slide. So, we have a 76-year-old male. And as expected, he is having associated comorbidities as hypertension, BPH, and a past history of PIBD, the past history of appendectomy, and presented to us with emergency with sudden onset hemiparesis. So he underwent an initial evaluation in neurology, and NCCT scan showed presence of brain mets. Further, then because of suspicion of being mets, he was followed in the oncology department, and a CMRI done in December 2023 showed also persistent brain mets with focal intensity lesion in the right parietal region, and a PET-CT scan done shows the presence of soft tissue lesion in the right upper lobe of lung, abutting pleura with FDG with hilar and parietal, hilar lymph nodes along with the right parietal lesions. There were suspicious bone lesions. There were sclerotic lesions seen in the D1 vertigo. Next slide. This patient underwent right lung mass biopsy, and thus biopsy was showing the presence of adenocarcinoma, and TTF1 was found to be positive, suggesting the tumor is non-small cell lung adenocarcinoma. And we ordered NGS because the patient was having a metastatic adenocarcinoma, and this NGS was suggestive of METex14 skipping mutation. Till the time NGS was done, patient underwent radiotherapy and underwent SRS for the brain lesions. Next slide. So after the completion of radiation, patient was started on tepotinib, 225 mg, 2 tablets OD to be taken at a fixed time of day. And for bone strengthening, we started injection denosumab 120 milligrams subcut every 4 weeks. This patient was followed. Next slide. So the patient tolerated the combination very well. There were initial complaints of having pedal edema, hypoalbuminemia, slight electrolyte imbalance such as hyponatremia and hyperkalemia, which was managed conservatively. Post 3 months of treatment, patient showed decrease in the size of lesions, intracranial lesions, significant decrease size from 16 to 5 on the lesions. There was significant interval reduction in the perilesional edema and interval reduction in the mass effect. Next slide. So PET-CT scan showed there is a complete metabolic response in the lesions of the brain, and there was significant reduction in the lesions of lung. Next slide. The patient continued. The side effects, including the pedal edema, were persistent. Rest of the side effects were managed with the diet. And then the patient, who was initially presented to us with the hemiparesis, regained his power, was able to walk with support for 6 months of treatment. A PET-CT scan shown that lesions were quite stable after a partial response. Next slide. So we continued the same treatment, and the patient has been continuing on the treatment for more than 1 year. After 1 year of therapy, MRI brain showed stable findings with no adverse changes, and PET-CT scan also shows that there was no FDG-AB lesions in the body. The disease was well controlled. Next slide. So in August 25, the patient had continued tepotinib. He had slight symptoms of pain in the chest wall. We did a PET-CT scan for response assessment. The disease was stable, and the patient is currently stable, continuing tepotinib. The only symptom he has persisted is persistent pedal edema. Albumin levels are well maintained with the diet, and thus the patient is tolerating the drug. Thank you.
Thank you so much, Dr. Varshni, for sharing your experience with tepotinib. So now moving on to the final segment of today evening, which is the panel discussion. For that, I'm delighted actually to introduce our moderator for the evening, Dr. Ulas Batra, sir. So, Dr. Batra is a senior consultant and chief of thoracic medical oncology at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. And he has over 16 years of experience in cancer care. He specializes in lung cancer and has authored more than 100 publications, recognized for his pioneering work in NGS based testing and AI integration in NSCLC. Sir is a respected faculty at global oncology forums, including IASCL and WCLC. Sir, we would like to invite you to take
Good.
forward the proceedings.
Thank you, Juhi. And can I share my screen?
Sure, sir.
Fantastic. So thank you, Juhi, for that nice introduction. And that also means that I am officially old. Thank you for letting me remind of 16 years and 20 years and 25 years. It's okay. This time will come for everyone, for you, me, and as well. And now I would like to invite my panelist. Professor Martin is already here. Good morning to you. Dr. Vaishnavi, we heard her convincing everyone that we should do NGS. And then I heard Amit Rautan's name, and I said definitely liquid biopsy has to be there. So Vaishnavi, please welcome. Ankur presented a case of METex14, which was fantastic. Ankur, welcome. Alok, is he here? So we just met Alok 2 days back in a different forum. Good to see you back, Alok. Arun has been there since beginning. I was seeing his there. So welcome, Arun. Anupam, hi, long time.
Yes, good evening, sir. Yes,
Long time. So Anupam,
nice to talk to you.
yep, we were colleagues at Rajiv Gandhi. Uh, Dr. Randeep, long time again. In addition to me, if there is someone who's getting old, that is Randeep. So Randeep also has similar amount of 20 years of experience. Randeep is the one which flaunts it. I don't want to flaunt it actually. And the last but not the least is Dr. Mubarak Tanse. So I will, okay, this is Dr. Mubina Tanse.
Yeah, I'm same. I'm here.
Okay. Now I was about to say Mubarak is congratulations. So I will like to rename you as Dr. Congratulations. Welcome, Dr. Tanse.
Yeah, thank you.
Okay. Uh, in the next 20 minutes or so, we will embark on a journey of MedChat. And my disclosure and conflicts of interest is the first thing which comes to my mind when I actually speak about Met is job we met. So I don't know how many of you know, but this is for Professor. This is a very, very famous Indian Bollywood movie which set the records rolling. And that is the first thing which actually comes to mind when we say Met. And when I think about chat, the chat GPT is the first thing which comes to my mind actually. But if I can be 100% sure that the Met chat that we just had and Professor Martin's talk was much more interesting than what both Met and chat GPT actually is. So I just want to make it even more interesting a bit. And let's talk about certain few things from there. So we will discuss about four things. Professor has very rightly, very nicely, told them in his talk. And if all of us were listening to that, we just have to say yes for everyone. So we'll first talk about the diagnosis of METex14. We'll then talk about the first line treatment, whether we go ahead with a single agent TKI or a chemoimmuno. And then we'll talk about which MET TKI. And then we'll talk a bit about the side effects. And it should not take more than 20 minutes. So this is what Dr. Vaishnavi showed. India is very different from the Western population. Our EGFR rate is around 26%. Our KRAS rate is only around 14%. I think is in the opposite in the West, where the KRAS is approximately around 28% and the EGFR is around 12 to 13%. That's one thing. The second thing is our ALK rate is much more higher than the Western population. We have approximately around 8 to 9% of ALK fusions, which are normally reported. And MET, I think, is similar 2%, 3% to 4% is what we normally get. Uh, the first question, and I will like to start with Dr. Vaishnavi only is, Dr. Vaishnavi, do you do NGS for all the patients? Or do you do NGS for only adenocarcinomas? And do you do it in squamous as well? Dr. Vaishnavi is not here. Fantastic. I will like to then go over to Dr. Arun.
Yes, sir. Yes, Dr. Ullas. We test it for all lung cancer patients, whether it is adeno or squamous. But in squamous, we hardly get any mutations.
Fantastic. That is what I was hoping for. Randeep, you get, I mean, we all say that, we get squamous and this and that because if we don't test for NGS in squamous lung cancer, Kumar gets angry. So we only do NGS testing because Kumar has to be kept happy, or do we get something actually?
See, actually, the problem comes is that when you start thinking about immunotherapy, you just want that you rule out, I mean, even less than 5% possibility that this patient will recently go on any sort of TKI. That is the whole idea to do it. But yes, you do get it. Somewhere down the lane, you start getting it when you do NGS. Maybe not to the tune of, as Dr. Arun said, of adeno, but you do get. And I think we shall test all squamous cancers for gene sequencing before putting them on immunochemo combination. That is what I do also.
Okay. So, Dr. Mubina, let's say squamous lung cancer, do you do for everyone? And what do you get? Approximately, what do you get?
Yes, I do practice NGS testing in both squamous as well as adeno. It's definitely, as Dr. Randeep said, it's lesser incidence, less than 5% probably you get uh, any targetable or driver mutation. But at times when probably we miss out adenosquamous histology in such scenarios, you may not have a homogeneous tumor population, especially when they are female, non-smoker. I tend to, do liquid as well in them.
I will want to stop you here and say, do you test for NGS in only in female non-smokers patients, or you test for NGS male 78 or male chronic smoker, hookah smoker, you will still test?
Everyone, all comers.
Okay. Let me talk to Professor Martin. Professor Martin, what is the status? What is the strategy that you apply? And if you do NGS for everyone, do you wait for immunotherapy to get started? Because in all the clinical trials, if you see, they just get an EGFR ALK exclusion. They don't actually insist on an NGS for everyone.
Yeah, it's a very good question. So we've done, and this is for simplification purposes, we see some transition between MET across squamous and non-squamous, obviously much enriched in adenocarcinomas. But in order to get reflex testing established, we basically made a call to say all non-small cell lung cancer histologies should be tested. I know that there's obviously a lesser and lesser yield for a squamous cell smoker than a squamous cell non-smoker or an adenocarcinoma. But for us, it was not about necessarily the frequency, but about the comprehensive capture of genomic testing. I think squamous should be included. And we learn a lot about NF1 and the Notch1 pathway and others that are becoming actionable as well. So we also use it as a pipeline for our research protocols. But for us, squamous is now included in all of our testing protocols.
Okay, looks like somebody is still doing OPD. Okay, so let me ask you, Professor Martin, once again. Let's say you have a 65-year-old male, chronic smoker, living in the most polluted city right now, that is Delhi. Additional double whammy. PDL1 is 70%. Squamous cell carcinoma. The patient has got liver, lung, and bones involved. The patient comes to you today. Would you send the NGS knowing that the chance is less than 5%? Will you start the patient on chemotherapy? Will you add immuno plus chemo? What do you practically do?
Any of the biomarkers very quickly. There are two considerations. One is the intensification of immunotherapy for resistance mutations. That's certainly something we've looked at, and also for obviously for targetable options. But in this case, I would say chemoimmunotherapy is perfectly acceptable to start.
I think Randeep, you would agree probably what Professor Martin said was right, and maybe a liquid biopsy or maybe a 3-day NGS, what the new CGP Thermo Fisher is advocating, also maybe a good idea actually right now. What are your thoughts on this?
See, I think if you can get it in a week, it all depends. But I think I also agree with Dr. Martin. When you treat these MET, they are actually not like EGFR ALK cross. The responses are there, but not that great. So the bulk of the tumor will matter. Also, if the patient is really having or going into a crisis, whether due to pulmonary load or due to liver load, I think it's better to start chemo IO. What I do in practice is I will start the chemo, send the NGS. Within that next cycle, we all do that. I mean, that is practical point. In the next cycle, we add IO so that we are in a safer side or on the one side of the fence.
The important thing right now, I mean, that's exactly what I do, Dr. Randeep. I mean, you do start them on first cycle of chemotherapy, wait for the EGFR ALK and the NGS report, add the immunotherapy from the second cycle. That's what we all do. But the important thing here is to test for squamous cell carcinoma. I think that is something important. In fact, today only we had a patient who had a squamous cell carcinoma. Probably she'll go to all the cities, hospitals tomorrow for a second opinion, and she's ALK positive. So it's not that we don't see. I mean, our rate of getting an EGFR is around 3.8 to 4.2%. ALK is also around 2 to 3%. We also get BRAF. A lot of people, I've got a lot of BRAF and, KRAS, not the 12C typically. But in total, around 6 to 8% of people will have some actionable thing, and it can make a difference. So we do NGS for almost everyone. That's the point which we were trying to basically say. Which basically again brings us to the point that even the NCCN guidelines say that even in squamous cell carcinoma, you should be doing an NGS testing. And especially as Dr. Tonse rightly said, if it's a female non-smoker squam, definitely do it. There is no doubt about it. So let me go to Dr. Alok. Alok, are you here?
Yes, I'm.
Alok, hi. So Alok, which MET alteration do you look for? Is it amplification, fusions, mutation, or it is exon 14 splicing mutation? I think it's the topic of the webinar is something, but we will still like to hear from you.
So upfront, we are primarily looking at the exon 14 splicing mutation. But when we are ordering broad spectrum NGS, we do get a lot of co-mutations and other mutations, and Maybe some are pathogenic and some are VUS as well. But exon 14 is what we are looking at in the
Okay,
NG.
let me ask you, let me ask Ankur. Ankur, are you here? OPD done? Ankur is not listening. Okay, fantastic. Alok, how does the report actually comes for a mid-exon footing? I mean, Professor very rightly said, the 14 is basically spliced out. How does the report actually come? It actually comes as met fusion 13, exon 13, exon 15, right? Isn't that the way the report comes? Because a lot of people come in the WhatsApp group and tell us that this is a met fusion. But if you have a MET exon 14 splicing mutation, the report actually comes as MET exon 13, MET exon 15 fusion, right? True that. Fantastic. So I will ask Professor Martin. Professor Martin, you rightly said and you elucidately explained in your conversation about doing an RNA-based sequencing. For the benefit of all the residents, why does the DNA NGS is not enough and why does RNA pick more? Just for everybody's benefit once again.
So I do want to say that the mutations are picked up if they're covered on the intron regions. So you can make an indirect conclusion of what is present. It is oftentimes not covered on NGS, so it makes it a little bit more challenging. And the RNA essentially looks for the entirety of the active the sites there, and you would see the direct connection between exon 13 to exon 50, and so you have a much more direct evidence of a skipping impact than you would have for testing. So there is a DNA value, and we can see, and you've had this in the VISION trial, you can see indirect evidence of splicing mutations on liquid biopsy, which is DNA based, but the sensitivity is simply higher on RNA based. So the RNA is really the direct proof of a skipping exon 14 event. So I would always favor having similar like we do for the fusions. I would like to have RNA confirmation for the absence of it. Now, if it's positive on liquid biopsy, I do trust it. And obviously that's then a complementary test to get tissue biopsy at the same time.
Okay, Ankur, what about IHC and FISH? We have the latest trials in which the Savannah trial, the Insight trials, in which we are also using the IHC. Do you use MET IHC or FISH, and when we look for amplification, we look for FISH, right? So do you use IHC, FISH, or you think a DNA RNA based NGS is good enough for you? Upfront, I'm not talking about the later settings.
I do prefer via the NGS method only, but DNA RNA changes.
So MET IHC is positive. Somebody has okay, I have done MET IHC positive. The patient goes to you for a second opinion. What will you tell the patient?
Getting 14 skipping mutation will be available, report will be available to us.
Ankur, I was not able to hear you. So let me go to Randeep now on this. Randeep, as usual, getting you into a tricky situation. I have ordered a MET by IHC. I don't know for what reason, and the IHC is positive. De novo. What would you do?
If you have ordered, there would have been a reason, especially considering lung cancer, first of all, that much we know. So, see, I think the people do this thing, but in the upfront setting, I will not, because though we know that as you said, in the recurrent setting, because even if MET fish comes positive in the first line, I will still prefer the patient to go on chemotherapy, because every data gets reduced by 50-60%. The response rate dips down from 60% to 30%, 40%. But yes, if you are not able to give chemo, and if I have to keep a very high cutoff, for example, I keep a GCN gene copy number of more than 10 and a fish more than 5, and the patient is not eligible for any therapy, that may be the situation as an offline.
To cut a long story short, please do not do MET by IHC in the first line if you are looking at a MET exon 14 splicing mutation.
Exactly.
In the second line, you can obviously use MET by IHC and you can start giving and confirm MET by FISH, and again with the FDA approved method, and start giving OC plus SAVO or OC plus TIPO or whatever together. But in the first line, I think NGS, DNA, RNA is something which is very important. Anupam, you have been silent for a long time. Do you send liquid biopsy? And if yes, when?
Liquid biopsy, I usually send in the recurrent setting if the tissue is not available.
Okay. So de novo patient comes to you today. Do you send a liquid biopsy? Because Professor Martin rightly said,
Yes.
that They will have a liquid biopsy. That
Yes,
basically
if
means,
possible, I will try to send both tissue and liquid.
why don't you send? If possible means, what is the implication that we are not sending?
Because if de novo, if person is elderly person, not amenable to FNSC only, but not biopsy possible.
Okay.
In this scenario where we cannot get the adequate tissue.
You like tissue, then only if tissue is
And
insufficient.
if tissue is not there, then the liquid biopsy is the
Fantastic.
option. Because in the liquid biopsy, we cannot, we do not know the histology or PDL1 expression.
Absolutely agree with you. Dr. Arun, when do you want to send a liquid biopsy? Do you send both of them together? And what has been your experience with that?
In our center, we test both tissue biopsy as well as liquid biopsy at the time of diagnosis for those who are affording. Yeah, because affordability is a big thing. Like each of these tests costs around 35 to 40,000. So most of the patients won't be able to afford it. So for those who afford it, we definitely send it both.
And what
And
has
in
your
concurrent
experience
setting,
been? What has your experience been? What do you get more out of it? Do you have any data or something?
yeah, because when we send tissue biopsy, we use
Okay, we seem to
kind
have.
of mutants like TP53 and all, which we can pick up in liquid biopsy.
Okay, I think I missed you. So Arun, do you pick up more DNA mutations? Have you picked up any? Can you remember offhand 10 cases
Yeah,
which have got
I
more?
had a patient. Yeah, I had a patient at diagnosis. He had a met. I had a patient who had a met copy number variation. I
Okay.
concurrently sent a liquid biopsy also, and finally the
Okay, we seem to be missing him over here. Dr. Mubina, what is your thought process and what do you
so
do in your experience?
I send at diagnosis for majority of my patients both solid plus liquid. It gives an advantage for additional detection. We might miss in case of 10% or 10 to 12% of the patients. Also, we can use liquid biopsy for monitoring VAF in subsequent settings as a real-time monitoring. One limitation of doing only liquid probably is we might get certain false negative results when they are not non-shredders.
Okay,
So
fantastic. Very nice. Randeep, coming back to you, what do you do? Real world practice.
Real world, actually, if you ask real world and practical, 80% they go on tissue only.
Correct.
And actually the concern is if I have to spend money, I will spend on a good NGS on tissue rather than sending two cheaper tests. If someone can afford it, a 1.5, 2 lakh, I will push them to send a Guardant or a Foundation and send it on tissue rather than sending tissue and liquid. Yes, if someone can afford, I would love to send both of them. But yes,
Many.
be prepared. There can be discrepancies, and so do it from a very, very good lab once you're sending synchronous.
Okay.
But 80% is tissue and 20% is liquid.
Okay.
That's
Okay. Alok, this patient, because we have just 15 more minutes. Alok, we have this patient who is a 70-year-old female. PS2 biopsy is showing adenocarcinoma. PDL1 is 80%, and METex14 is there. So you have options. Okay, let's make it 55-year-old male, PS1. The immunotherapy, I mean, for the PDL1 is 80%. METex14 is there, and patient is a lawyer by occupation. Which one will you go in for first?
So would be inclined to use a non-chemotherapy, non-immuno option. So
Why
that
a patient wants, or okay, fine, forget it. Let's say this is a MSG symposium. Let's not say it's a Merck symposium. Let's say it's the other Merck symposium. What would you do in that patient?
I mean, even though PDL1 is 80%, the responses to an IO chemo uh, might not be superior to chemo alone in this situation.
Absolutely right. Absolutely agree with you. And let me go to Arun. Arun, are you back on track? Do I have your Arun? Okay. Anup, Dr. Ankur?
Yes, sir.
Yes. So PDL1 80%, MSD symposium, pembrolizumab keynote 24 and 42 symposium, PD-L1 80%, 55-year-old female, PS1. PD-L1 80%, METex14.
So if this is a METex 14 direct mutation, I will like to go with the tepotinib. In case
The
of
MSG people are going to be very angry with you. What
no
will you do?
issues.
No issues. Fantastic.
In case it was MET amplification, I could have a second thought.
Okay, we are not talking about MET amplification right now. We are talking only about this. Dr. Mubina, do you agree? Absolutely.
Yeah, absolutely. It's right to go
I
ahead
think
with
correct. I think we all agree that, I mean, this was the records, and this is this is actually our data. This is our and combined Tata's data. We had some 48, 49 patients. And what we basically found out was the median PFS with the first line, either the tepotinib or the other one, is actually 11 versus 6 months. Even the second line, this was better. And this was a together study, basically, which which did an indirect analysis. And they basically found out that, if you have the oral TKIs, the even if you give immunochemo, the PFS was 7.8 months. With the MET TKI, the PFS was around 14 to 15 months. It's an oral tablet. And in the second line also, the responses are much better over there. So I think the increased response rate, oral tablets, no need of coming to hospital thrice, the increased PFS. So I think this thing has to be there, that if a patient has been METex14 skipping mutation, we need to give the patient an oral medicine if the patient can basically afford that. And this is there in the NCCN ISMO guidelines also. Which MET inhibitor, Randeep? Let's say it's a other symposium, the other.
I think there is not much different between the drugs, but it also depends upon your practice and comfort level. Maybe my comfort level is more with tepotinib, but I think there is nothing against capmatinib. Though yes, it is given twice a day, and then the dose reductions. I mean, 400 you have to do to 300, and then it is. Those are, I mean, more of logistic things. Practically, if you see, I don't believe in this cross-trial comparisons, as well as even yes, the professor also did show some data, but to my mind, both are equal, and the practice and comfort depends upon your experience with the drug as a medical oncologist.
Absolutely right. I think which is 1 rupee cheaper, although the data is more in favor, slightly more in favor of tepotinib. It's an indirect association. There is no one line data. So, but still 1 day and slightly better, we would want to give that. But that is something which is there. Okay, let me go to Dr. Arun. Arun, are you here? Okay. Anupam is there. Anupam, let's say a patient has got, you do an MRI brain, and the patient has got 3 or 4 asymptomatic brain lesions. Would you want to give, and your best friend is a radiation oncologist, would you want to give radiotherapy to the brain lesions and then give tepotinib? Or would you say friendship is separate, as the professor is actually smiling on this? Do you have a radiation oncologist sitting next to you, professor?
Because studies have shown that, as with other TKS like third generation EGFR or ALK inhibitors, which have a higher efficacy, intracranial efficacy, both active and inactive disease, I think this molecule has also data shows that the good efficacy, intracranial efficacy. So even if asymptomatic patients, probably we can manage with only TKI.
I think I
Plus steroid if required. Otherwise,
absolutely agree. In fact, if you look at this, the disease control was 88.4, 67% was a response rate. So friendship is separate, but I think we would rather go ahead and give tepotinib, and this was the data which was there. Now, this is something where, Professor, I would like to have your comments, and I was saving this for you on the safety. I mean, there are two things which come to my mind, three things actually. One is the creatinine increase, which we know is because of the MATE receptor blocker, not bothered about that. One actually is about the pedal edema and the, even increase in pleural effusion and ascites, which is there. I've got at least 3 patients who have got such a bad edema, maybe because they didn't follow up earlier, maybe because we didn't reduce the dose on time. And even if we reduce the dose on time, once tablet, the pedal edema is very, very, very troublesome. So 2 things. One, how do we minimize? And second thing is, once the pedal edema sets in, other than the conservative measure, is there some steroids? Or I was reading a trial of VEGF, ramucirumab plus tepotinib also, which is going. How do you treat it?
Well, I mean, there are a number of efforts. At first, always recognizing that this is an on-target effect that is inevitable. We don't have a differentiation in target structure. So it's something we'll have to deal with in the majority of patients. If 67% reported it's really probably every patient, and some patients underreported. And all the downstream effects, creatinine increase, electrolyte shifts, etc., coming from appropriate management of intravascular fluid pressure, oncotic pressure maintenance. So my experience is that some of the measures we've been doing in the trial were actually counterproductive. The use of diuretics may cause more intravascular depletion. If the whole body is fluid overloaded, salt restriction may actually cause further hypernatremia. So my experience is you have to intervene and detect it early. Once you have substantial edema, it takes a long time to resolve, and it's oftentimes too long for our comfort level to stop the drug. And so you really have to catch it on the rise and dose adjust. And we've been very creative with the dose adjustments on the go. I think that the packaging of the drug actually lends itself to doing this very easily on the go. The patients don't incur additional copays or other concerns. But my main strategy is either either that or adding a VEGF inhibitor. We don't use ramucirumab because of cost here, but the bevacizumab addition is certainly one that we've tried to maintain vascular integrity. But it's only sort of a part of a bigger strategy. I think the heart and center is dose adjustments, and I wished I would have showed the data for dose adjustments, showing that the 225 and 450 data really don't seem to impede on the issue. And again, whether it's the MET antibodies, amivantamab, we see it here now with TILOCV and others. MET targeting will cause edema, so we'll have to get good at managing it.
Okay. So I think that is what was there. I think dosing convenience is very good. I think more than the dosing convenience, I would actually talk about the dose interruptions, which is very much easier with tepotinib. It's just 2 tablets and then you make it 1 tablet. For capmatinib, although my initial experience was much more with capmatinib, but tepotinib has actually made my life very, very easy. Start with 2 tablets, go on to 1 tablet over there. So with that, I come to an end. I have 3 take-home measures which I would like to give. First is do NGS for everyone, whether it is adeno or NOS or sarcomatoid or squamous cell. Do it for everyone. Ask your lab if they are doing an RNA-based NGS. That is number 2. Second is do not please treat only on the basis of PDL1 value. Wait for the NGS report and then add immunotherapy or a target therapy. Liquid biopsy is good if you can get it, but practically we are not able to get it. But the most important message which I actually want to give here is please look at the patient, call them every 2 weeks, look at their weight, look at, as Professor rightly said, look at whether their feet swell, their clothes swell, weight recording and everything has to be there. Because once the edema sets in, it is an absolute difficulty. I have had patients who have got edema, pleural effusion, ascites, the disease is under control, but the edema is the one which is actually translating. So catch them early, call them once in every 2 weeks to start with. It's a fantastic drug. Delay immunotherapy, you can always use them in second line. We do biopsy of these people on. So, Professor, last question to you, which was not a part of this. How do you treat a progression on that? Any role of multikinase, cabozantinibs, and everything? How do you treat them on progression?
I don't have very good success. So if a patient here goes on to progress on a MET inhibitor, the resistance mechanisms are very difficult to capture. So I don't think of this as a good sequencing opportunity. Cabozantinib with a lot of challenges, both from a toxicity and from an efficacy standpoint. I would try that later. I would probably go next to chemo IO. And use that as my next standard of care. We have some data from Chrysalis about amivantamab, which has a different set of challenges as an antibody, both targeting EGFR and MET. But I think this would be a good strategy to see if MET is still expressed, obviously, ideally with the biomarker sorting. But chemo IO would be my next second-line standard of care.
Absolutely right. What did you say? So you would say that you give tepotinib because amivantamab can be easily procured in our setting. Money may or may not be an issue. Do you think I'm not aware of any data of amivantamab after tepotinib? Are you aware
There's
of?
no data. There's no
There is
data.
no
This is de novo treatment for MET disease.
So
It's just
by
a
and
switch
large,
mechanism.
yeah, but by and large, this is exactly what we do. We start with MET TKIs, give them chemo immuno later on. If the patient tolerates them, continue on immunotherapy, then probably give them cabozantinib at the when they progress on that. And then I don't think we have many patients going beyond the third line. Uh, but that was a very nice interaction with everyone. Thank you all my panelists and thank you Professor Martin for a very nice interactive discussion. And I see Dr. Advani has joined, and back to you. And good evening, sir, to you.
Yeah, good evening, Ulas. I think I've been listening to it, that how, we are really going to improve our full real world experience in terms of the looking at the best for the patient. So I think it's very clear that now lung cancer means the NGS is a must, minimum, maybe more at the level of RNA and the protein level. But NGS is a must. The second thing, which is I think is the most important thing, is that today's data indicates, although somebody mentioned that both are equal, but I think tepotinib seems to be little better as compared to the tapmatinib. So, but one thing which we have also realized, that the METex14 skipping cases also needs to be treated with the targeted therapy first rather than the PDL1 if that is also high. Then it does, for any case, normally I always feel the target therapy is the best rather than any other treatment. And there are, of course, the tepotinib has got the better CNS penetration and therefore can be useful in that. And the adverse event, especially the peripheral edema and all, is critical, and that has to be really carefully looked into it during the follow-up. I think with these few observations, I would like to really thank all the speakers, all the panelists who have given us such an excellent insight as to how the newer information on the molecular mechanism is allowing us to improve our effort in terms of saving the life. Thank you very much.
Thank you, sir.
Thank you so much, sir, and thank you to all the faculty members and also our audience for joining in. I wish you a great evening ahead. Thank you.
Thank you. And good morning to Professor Martin. See
Yes, good morning, sir.
you a long day ahead. Bye. Thank you.
Thank
Thank
you.
you.
And good night.